The autonomic nervous system regulates and integrates internal functions in the body to automatically react to changes in the body's internal and external environments through either the sympathetic fight or flight system and its opposite, parasympathetic rest and digest system. Adrenergic receptors are receptor sites that respond to norepinephrine and epinephrine, while beta receptors are also found in the heart, the lungs, and the vascular smooth muscles. Alpha and beta agonists increase vasoconstriction and so can exacerbate atherosclerosis and peripheral vascular disease. Box 30.1 focuses on drug therapy of adrenergic agonists in children, adults, and older adults. Adrenergic agonists are drugs that mimic the effects of the central nervous system and can affect both the alpha and beta receptors. They are typically used to correct hemodynamic imbalances in shock, which includes decreased heart rate and decreased blood pressure. They work by activating the sympathomimetic response to both alpha and beta receptors to increase the blood pressure, increase cardiac and urine output. Drugs in this class include dopamine, dobutamine, epinephrine, and norepinephrine. The choice of drug is dependent upon the effect that is desired for the patient. Adverse effects of drugs in the class of adrenergic agonists include the development of arrhythmias or hypotension, dyspnea, and these drugs can extravasate into the tissues and damage the tissues around the IV site if the IV infiltrates. When a patient is on an adrenergic agonist that is causing vasoconstriction to increase the blood pressure, that vasoconstriction may limit peripheral circulation, causing necrosis of the fingers and toes. Therefore, monitoring the peripheral pulses is an important nursing action when caring for these patients, as well as monitoring blood pressure and urine output and respiratory function, since these drugs impact both alpha and beta cells. Caution should be used when administering these drugs to someone with a previous cardiac disease because of the increased workload on the heart that these drugs cause. Figure 30.2 in your textbooks describes the sympathetic nervous system and the physiological effects of adrenergic stimulation. There are some drugs that are alpha-specific adrenergic agonists working only on the alpha cells to cause vasoconstriction, elevating the blood pressure and cardiac and urine output. Phenephrine is one of these drugs. It is given IV to treat patients experiencing shock and can be used as a topical decongestant to treat nasal congestion and middle ear infections. Given as an ophthalmic solution, it can be used to dilate the pupils. Please review box 30.2 on the safe administration of ophthalmic medications. Adverse effects of these drugs include restlessness and anxiety, blurred vision, arrhythmias or hypotension, nausea, vomiting, and anorexia. And again, these drugs can cause tissue extravasation if the IV infiltrates. Of note, these drugs, phenephrine, can be found as an addition to other colds or ocular medications. The drug should not be stopped abruptly because of the rebound hypertension that can occur, which will also lead to arrhythmias. The drug needs to be tapered over a 2 to 4 day period. Chapter 31 talks about adrenergic agonist drugs. These drugs block the effects of the sympathetic nervous system. They have varying degrees of specificity, and the drug choice is based upon the desired effect and the decrease in the undesired side effects of the medications. Figure 31.1 describes the site of action of adrenergic receptors and the resultant physiological responses that are blocked by the adrenergic blockers. These drugs may either be non-selective and block alpha and beta receptors, or they can be selective, blocking only beta receptors. In the non-selective adrenergic blocking class of drugs, we find carvedilol, labetalol, and amiodarone. Note that most of the drugs in this class that are beta blockers will end in LOL. They block the effect of norepinephrine at both alpha and beta receptors. What that results in is a decrease in heart rate and a decrease in blood pressure. These drugs are mostly prescribed for individuals who are experiencing hypertension. Carvedilol improves cardiac output and slows progression of heart failure. So when choosing a drug for a patient with heart failure in this class, carvedilol is often the drug of choice. Labetalol is typically given IV and used to treat hypertension. Amiodarone is used to treat ventricular arrhythmias. For the entire class of drugs, the adverse effects are similar. They may cause hypotension, orthostatic hypotension, since it blocks the alpha-1 receptors in the cardiac arrhythmias and bradycardias, and can lead to heart failure and stroke. Because the beta receptors are blocked, the respiratory system can suffer from bronchospasms, and in the genitourinary system, male patients may suffer from erectile dysfunction with use of these drugs over time. Patients with asthma should be cautioned and given these drugs very cautiously because of the effect of norepinephrine and bronchodilation is lost with these drugs, and the usual sign additionally of hypoglycemia and hyperglycemia are blocked. So use of these drugs with an individual with diabetes requires education on the patient becoming aware of different ways to identify when they are having hypoglycemic or hyperglycemic events. Please review box 31.2 regarding herbal therapies and the use of these drugs. Also review the rationale for non-selective adrenergic blocking agents and how you work with patients and teach them when they are prescribed these drugs. The next class of drugs are the non-selective beta adrenergic blocking agents, and propranolol is the drug chosen out of this class of drugs for discussion. Ophthalmically, timolol is another drug that can be used that is a non-selective beta adrenergic blocking agent, and it is typically given per drops to treat glaucoma to reduce intraocular pressure. The class of non-selective beta adrenergic blocking agents block the beta effects of the sympathetic nervous system in the heart and nephron to decrease blood pressure, decrease oxygen consumption, and decrease the workload of the heart. These drugs are given to individuals who are experiencing hypertension, who have angina, and may be used post-myocardial infarction to help to prevent a reinfarction. Non-selective beta blockers may also be used to treat migraines or stage fright, but they are not approved by the FDA. This is an off-label use for these drugs. The class of drugs can produce fatigue and weakness, bradycardia, heart failure, or hypotension as an effect from these medications. And respiratory, they can cause bronchospasms or pulmonary edema. And again, for male patients, erectile dysfunction may occur. Stopping these drugs abruptly can lead to myocardial infarction, stroke, and arrhythmias because of the rebound effect of the sympathetic nervous system. Again, blood glucose levels must be monitored carefully for individuals who have diabetes because the signs and symptoms may be altered for hyper and hypoglycemia. And also we need to be aware of monitoring patients for signs of heart block. Monitor liver function as well with these drugs, and the use of NSAIDs and beta blockers can decrease the antihypertension effects. So you need to advise patients not to take an NSAID if they are also on a beta blocker. There are beta blockers who are selective, and they are selective adrenergic blocking agents. So they decrease the blood pressure, decrease the heart rate, and decrease the excitability workload as other blocking agents do. But these are the drugs that only block beta 1, and so they are preferred to give to patients who are experiencing asthma or COPD as a condition, along with their hypertension. They do not block those beta 2 receptors in the lungs, and so that they do not block bronchodilation, which is extremely important for patients who have lung disease or allergic rhinitis. Two of the drugs in this class include metoprolol and atenolol. These drugs, in addition to being used to treat hypertension, can be used for individuals with angina or who have stable heart failure, and beta-1 selective blockers are a core measure to be used to prevent reinfarction for individuals who have experienced a myocardial infarction. Again, the adverse effects are similar to other beta blockers in creation of hypotension, heart failure, and bradycardia as adverse effects. They can also cause bronchospasm, although not as frequently as with the other non-selective beta blockers, and the individual may experience fatigue and weakness, and again, erectile dysfunction is common to all the beta blocker drugs. The drugs can be given orally in regular or extended release and IV. If the individual has been on these drugs for a long period of time, they need to be tapered, and you have some key points that talk about administration of these drugs and tapering them. Blood pressure, pulse, EKG, and blood glucose, particularly for individuals with diabetes, needs to be monitored. The drugs do not block sweating, which is a sign of hypoglycemia, and so being aware that the individual needs to understand new signs of hypoglycemia is very important. These beta blockers, the beta-1 selective blocking agents, need to be given with food to increase absorption. And again, these are the drugs that are preferred, but even though they're preferred, you need to be cautious in giving them to patients with lung and thyroid disease. Please review the boxes and the focus on drug therapy across the lifespan and the critical thinking scenario about the non-selective beta blocker use.